I'm going to talk about pre-hospital airway management, but I'm really pleased to see that the themes of my talk are very similar to the theme of David's talk, in keeping with intubating a population of patients outside of the operating room. So I'm going to talk a little bit about what's different, and I guess the main things to focus on are that in hospital, even outside of the operating room, you can still, to a degree, control the environment. You can control the scene, you can control the light, you can control the temperature, but to a degree, you can control the people, although that might be something we can do better, actually. Whereas the out-of-hospital environment, this is just one of a million possible places that someone can be intubated in the pre-hospital environment, anywhere from a living room to a toilet, to a stadium, to a car in a ditch. We have different equipment as well, but as has already been touched on, that's probably a good thing. We don't have the trolley that everyone's got their special toy in, that you open it and things fall out. The space and the weight constraints limit us to a small amount of equipment, which can be selected in advance and trained with, so that's probably a benefit. But I just want to be clear, for those of you who aren't familiar with the pre-hospital environment, even though it's the same patient having the same procedure, often by similar people, there are significant differences, and that's what I'm going to spend this talk trying to educate you a little bit. I was told not to be too controversial, and I'll try. So I'm going to talk about the history of pre-hospital airway management, a little bit about who we intubate pre-hospital and discuss the evidence that there may or may not be to support that, talk about who should be intubating pre-hospital, and then finish by talking about what you in hospital have already learned from us and what you might learn from us in the future. So I did a bit of research for this talk, and I tried to find out when the first paramedic intubation was. As opposed to the first pre-hospital intubation, I think the first pre-hospital intubation was almost certainly during World War I. The first paramedic intubation, as far as I could ascertain, was in 1967, when the Freedom House ambulance was set up in Pittsburgh in the US. This was an ambulance service that was set up by a man called Peter Safar, who some of you might know as the father of intensive care medicine. He set up this ambulance service to service underprivileged black areas of Pittsburgh, which white ambulance services refused to go to because they wouldn't be paid. And he hired men from those underprivileged areas, black men who had been labeled as unemployable by the council, and trained them to be paramedics. And about 90% of them went on to pursue advanced degrees and professions after their time with Freedom House Ambulance. So that was the first paramedic intubation. Now, coincidentally, only 4 years later, the first pre-hospital intubation in Australia, or Australasia, occurred here in Melbourne with the advent of the Mobile Intensive Care Ambulance, or MICA program, which still exists. And I found this photo in the archives as I was preparing the talk, and I'm now thinking about mandating spectacular sideburns for MICAs again, just as an ode to history. So who do we intubate? Well, there's a bunch of people we intubate pre-hospital, but the two biggest groups would be cardiac arrest and severe traumatic brain injury. So I'm going to talk a little bit about the evidence for those two major indications for pre-hospital intubation. Going first to cardiac arrest, there's 3 trials that looked at whether or not we should be intubating pre-hospital and cardiac arrest. Coincidentally, all were published in JAMA in 2018. The first one, the JABRA study, was in France and Belgium. They randomized about 2,000 odd patients to intubation versus bag valve mask ventilation. Quite a good outcome measure, favorable neurology at 28 days. They found no difference in outcome. Just a trick for those of you, if you're not used to looking at cardiac arrest data, that survival rate seems low. So in Australia and New Zealand, most ambulance services have a survival rate in all comers of about 10-12%. In some countries, you do tend to see those survival rates of 4, 5, 6%. That usually means that ambulance service doesn't allow paramedics to withhold resuscitation in unwitnessed asystolic arrests, whereas in other ambulance services like here, our paramedics will withhold resuscitation in that population, and that gives you that little extra bump in your all-comer survival rate. So, not great. The other trial was done by Henry Wang and the group in Los Angeles. A bunch of US ambulance services randomized 3,000 patients to combi tube versus intubation in cardiac arrest. For those of you who are not familiar with the combi tube, the best description I heard of it was just recently, actually, where someone described it as a very complicated way to kill someone. But it's basically this thing, this giant thing that you just jam in the mouth, and most of the time it goes into the esophagus. Sometimes, if you're lucky, it goes into the trachea, and then there's a complicated series of balloons to try and figure out where it is. They had a really weird outcome measure of 72-hour survival, which is meaningless, but they did show a survival benefit with the combi tube for what it's worth, although that survival benefit didn't continue on to the patients going home. The most important study for us is the one that reflects our practice, which was the Airways 2 study, which was done in the UK. A bunch of UK ambulance services randomized 9,000 patients, supraglottic airway in the form of an eye gel versus intubation. Good outcome measure, neurological outcome at 30 days, no difference. So this came as quite a shock, as you can imagine, particularly to the paramedic community, who began to see that intubation may no longer be in their scope of practice. And there was quite a bit of consternation, particularly amongst UK paramedics, where there isn't, at the time, there wasn't a strong critical care paramedic focus. Very unusual for paramedics in the UK to be trained in drug-facilitated intubation. And as I mentioned, we've had MICA paramedics in Victoria now for 50 years. Intubation has become so established in the scope of practice that it's become part of the identity of a critical care paramedic. And all of a sudden, for a study to come out and say, well, the evidence doesn't stack up, sorry. But as a result of that, I think it's fair to say most ambulance services have either removed or seriously de-emphasized intubation as a component of cardiac arrest treatment. So the patients we will intubate are, if you get ROSC, obviously, or if it's a patient being transported under CPR for ECMO, we will intubate those patients. But most other patients will be managed pretty well with a supraglottic airway. Luckily, there is another indication that allows paramedics to keep their skill and not get too upset, and that's rapid sequence induction for traumatic brain injury, although still controversial. So why would we want to intubate someone pre-hospital? Well, the teaching is we want to prevent secondary brain injury. Secondary brain injury is a result of hypoxia, hypercarbia, and hypotension. So we want to make those three things better if we can. As David has already pointed out, we might make one of them worse by making 40% of people hypotensive after induction of anesthesia. The other thing we have to think about is time. Are we going to delay the time that it takes for the patient to get to definitive treatment by doing this procedure? There's been 2 trials, which are quite well spoken about, and most people would know about them. The first trial with Daniel Davis in San Diego, who was conducted in the late 90s, early 2000s. This was kind of a bit of a death knell for paramedic RSI in the United States because it showed a dramatic increase in mortality in patients with severe traumatic brain injury who received pre-hospital intubation by paramedics. But I think it's important to specify that they trained every paramedic in San Diego to do RSI on a 1-day course and then let them loose. So most of them got very little exposure to the skill, and when they did, we saw things like this with prolonged intubation attempts, very poor first-pass success rate, significant hypoxia, the patients arrived at ED with end-tidal CO2s anywhere between 20 and 60 because they didn't have waveform capnography, they just used easy caps. So I think this wasn't a well-conducted study, and I think most people would agree. And it also wasn't randomized, it was a case control study. The other trial was done here in Melbourne by Steve Bernard and colleagues, a randomized controlled trial of paramedic intubation for severe TBI with an outcome measure of Glasgow outcome score at 6 months, which did show an improvement in survival. And on the basis of this relatively small trial, about 300-odd patients, it didn't show a difference in mortality, but one could argue that mortality and traumatic brain injury, the way we practice intensive care here in Australasia, can be a bit of a self-fulfilling prophecy, and that a longer outcome measure like that is perhaps a better measure. Anyway, I think that this has helped, but there are still a lot of people who say, okay, well, you can fix hypoxia, you can fix hypercapnia with intubation, but what about scene time? Well, that may not be as important as we think either. This is quite a neat little retrospective study where they used regression analysis to look at the effect of various interventions or lack thereof on mortality in patients with multi-trauma. And they showed that, sure, if you're hanging around on scene for a long time, you'll increase mortality. But if you're hanging around on scene to do something meaningful, the mortality effect seems to cancel out. So that's useful, because at the end of the day, if a doctor comes up to me and says, your paramedics take too long on scene, when they intubate, it takes the patient an extra half hour to get to hospital, I can't argue with that. It's true. on-scene intubation does take time, but I think we think about it the wrong way. We need to think more about the patient's journey. And every patient is on a journey, and there are specific times when an intervention may or may not be useful. And a lot of people say, pre-hospital intubation means the patient takes longer to get to ED, but I think that's the wrong measure. I think the measure should be, does an intervention delay time to definitive treatment? Is that procedure part of the definitive treatment? And if it's not, are you delaying time to definitive care? And for a severe traumatic brain injury, I would argue that definitive care is getting a CT and then getting to the operating room if you've got an expanding hematoma. And so I would be interested, I would think that, and it would be a really interesting study to do, to look at, and someone may have done it already, and I'm not aware, to look at the time taken to intubate someone pre-hospital versus the time taken to intubate someone in the ED. I think you'll see a lot more heterogeneity in the ED. Some EDs will be super slick, and some won't. And you'll probably see a similar but lesser degree of heterogeneity in the ambulance service. But I suspect what you will see at the end of the day is the time taken to definitive care probably doesn't change. I think we also need to think about what modality we're using. If someone's an hour and a half away and is being flown to the hospital, they're in the back of a helicopter, which is just a small, noisy, vibrating ambulance, which can't pull over to do anything. You need to intubate them first. I don't think anyone would argue. If you're in a metropolitan area, 20, 30 minutes from a major trauma center, then you need to think very carefully about what you're doing. But I still also would hold that, many paramedics are frustrated by showing up to an emergency department with a hypoxic patient with an uncontrolled airway, and then standing there watching, like the scene we saw before, 45, 50 minutes of fluffing around before the patient's intubated, when they think, well, I know I could have done that in 20 minutes in the back of the ambulance. There's a few other indications: stroke, overdose, respiratory failure. Humanitarian is one that often gets spoken about, which I think is quite important. If someone's got multiple fractures or severe burns, they're going to be intubated at some stage in their journey of care. Why not do it sooner to control their pain? Although I must say, with the use of multimodal analgesia, as our paramedics get more experience with ketamine infusions, we're doing less of this. No evidence really to support any of these other indications. Slightly controversially, who should be intubating? Should it be dashing, good-looking Hollywood doctors or crusty old ambos with long socks? Well, the problem is when you start having this argument, people get very, very emotive, because everyone thinks they're really good at intubation, even if they're not. And people get really into this on Twitter. So this coincidentally is a Twitter poll that I saw just a few days ago. Every now and then, if those of you who are active on social media, if I can give you one piece of advice, every now and then I'll see one of these Airway conversations happening, and I'll respond, and I'll instantly regret it. Because there are we've heard the word zealot a couple of times at this meeting. There's a lot of zealots. What does the evidence say? Well, the evidence, if you look at a broad population, says that doctors are better at intubating than paramedics. When you dig a little bit into the data, most of these doctors are anesthetists, and most of these paramedics probably aren't intubating very often. So I think in all comers, sure. You can't argue that someone who does it every day is not going to be better than someone who does it. Actually, many paramedics will intubate every day if they're working in a good system, but if they're working in a system that doesn't direct the critical care paramedics to the sick cases, they may not be. Looking at specific systems, though, and not to blow our own trumpet, these are data from here in Victoria. In adults, our first-pass success rate's 89%, and overall success rate 99% with our flight paramedics, which is the same as the doctors in the previous study. With children, we're actually better than non-anesthetist doctors. First-pass success rate 93, intubation success rate 99. Again, this isn't trying to boast. This is just saying this is possible in the right system with the right training and the right governance. What have you learned from us? Well, one of the things that we can offer in the ambulance service is a hierarchical paramilitary system based on our history. And it would be remiss of me not to mention our paramilitary history without mentioning the world's most famous ambulance driver, Queen Elizabeth, who died a couple of days ago. Because of that, now there's lots of problems with hierarchy. There's lots of problems. You know, any of you who read the paper from here in Victoria will know that Ambulance Victoria has been going through some really troubling stuff recently related to culture and bullying and harassment and incivility and discrimination. And a lot of that relates to the paramilitary hierarchical culture that continues to exist in ambulance. There are a couple, and we need to change that, and we are changing it. I think it's already been mentioned a couple of times here already. We do also need to think about, are there any good things that can come from hierarchy and from having people who follow the rules? Because I would say unequivocally, in terms of who should be intubating, I don't think it matters. I don't care who's managing the airway as long as they're well trained, well governed, and working in a system that allows them to be re-credentialed well. But one thing that paramedics hands down are better at than doctors is following rules, following guidelines. Doctors don't follow guidelines because we think we know better. Paramedics follow guidelines because they've come, I think, incorrectly from a system where they're worried about losing their job if they don't follow the guideline. And so that's something that we do well. And our guidelines are freely available online on the App Store, anyone who wants to use them. What else do we do? What have we given you? Well, checklists. Checklists came from I think London HEMS was the first pre-hospital service to use and popularise checklists, and now they're used the world over. This is an example of our checklist here in Victoria. Pre-hospital checklists are usually a lot simpler than in-hospital checklists. They're a lot shorter because there's a lot more that can be assumed about what's happened before, whereas when you throw together a crash team in hospital, there's a few more things you need to check. Kit dumps for the inexperienced intubator or infrequent intubator came from pre-hospital care, as did pre-drawn syringes. So there's quite a few things that have come from our environment that are now commonplace in hospital. Something that I think you should take from us, which I don't think you have yet, is highly standardized training and credentialing. And I'd just be keen for a little poll. I'd like you to put your hand up if you're someone who intubates as part of your scope of practice, and if you've ever had to undertake a high-stakes, career progression limiting exam that assessed your ability to safely intubate someone. A couple of paramedics have put their hand up, and none of the doctors have. This is something that I think we do better. We make sure people can do it safely before we let them do it, whereas in medicine, I think there's still a lot of see one, do one, teach one. And I think we do our teaching well, and I'm just going to close with a little video. Again, not to blow our own trumpet, but to say that I'm very proud of the team that made this video. I've just some little snippets of it from a much longer video, but if anyone wants the actual video, please come and see me. Just to show you how we've started training our paramedics in the idea of shared mental models and common language. Hi everyone. Intubation is one of the cornerstones of intensive care paramedic practice. Anyone who carries out intubation as part of their scope of practice needs to be familiar with the difficult airway algorithm.
Are you happy to run us through your airway briefing?
Sure. Cool. I'm going to use plan A, B, C, D approach for this patient. Plan A will be a video laryngoscopy with a MAC4 blade, a naked bougie and a size 8 tube. Plan B, if I need to move to it, will be video laryngoscopy again with an X blade and a hyperangulated stylet within a size 8 ETT. Should I have any difficulty with either of those or critical desaturation at any stage, we'll move to rescue ventilation, which would be plan C with an SGA. And if that is unsuccessful, we're into plan D, which is can't intubate, can't oxygenate scenario, and we will move to a crike situation where I will ask you to perform the crike for me.
Perfect.
Medication-assisted intubation is a team procedure, and the DAG acknowledges the importance of crew resource management in mitigating communication-related errors. CRM supports a team-based dynamic with a productive authority gradient where all members can raise concerns or offer advice.
I'm going to demonstrate the technique now, not in real time obviously, talking through as I go. So the first thing we need to do is obviously we've already declared that this is a can't intubate, can't oxygenate situation. One of your paramedics will be still attempting oxygenation at all costs during the procedure. And there is actually some evidence that having a supraglottic airway in situ may make the procedure slightly easier by bringing the larynx forward anyway. So this won't be detrimental. But one thing that is important about the procedure is that the position, the optimal position to perform a surgical airway is different to the optimal position for intubation. So whereas the optimal position for intubation was ear to sternal notch, we now want to have the neck as hyperextended as we possibly can. So power of education, credentialing, governance, I think is something that we can seriously offer, that we already are doing well in the pre-hospital space, that it would be nice to see happening in hospital. Thank you.